Hey, this is Moyo, your neighbor Psychiatric. I'm here with Ms. J. Did it?
Hey,
How you doing today?
I'm doing wonderful. I'm blessed. Thank you
Oh,
so
well,
much for having me back.
yeah, you're welcome, you're welcome, you're welcome. Yeah. So today we're going to talk about the psych intake for patients. It's a long intake, but we're going to talk about the first part of the psych intake. We're going to talk about the demographics, what used to be called the chief complaint. Now we call it concern.
Okay.
Because complaint didn't sound okay. I even use chief concern. I don't use chief complaint.
Okay.
So we're going to talk about demographics, chief concern, what brings them here, the history of present illness, and then a little bit about the past medical history.
Right.
Yes.
So let's talk about, to begin with, what is a psych intake for those people that don't know what an intake is?
Well, a psych intake is when you first meet the patient, when they first come to you
Okay.
for services.
Okay.
You do an intake.
You intake. So you're gathering,
yeah,
you're
get
gathering
all
their
the
personal
data. Yeah,
information. Personal information about them and where they live and their
Yes.
race, and because a lot of people don't really know these terms. They're basic and
They
simple
don't.
to us, but a lot of people don't know what is an
Yeah,
intake.
yeah,
So it just to make it clear for those who don't know, who are trying to educate themselves by watching the No Scrubs or White Coats. That's what an intake is.
Yeah,
It's
yeah.
just
So when
gathering
you-
of
when-
information.
When you first come to see like an NP, a nurse practitioner,
Right.
that first time you see them, whether you come from someone else or you just new to psychiatry,
Right.
we'll do what's called a psych intake.
Nice. And that consists of is what you're going to talk
Yeah,
about.
we're going to. It's longer than what I'm saying, but we're going to do the first part today.
Okay.
We're going to break it down little by little.
All right, let's break it down to the
Yes.
beginning. So, the demo.
Yeah, so we start with demographics. That's detailed. Like, it is like 20-year-old man, African American, Hispanic,
Okay.
whatever.
Okay. So the
So,
demographics,
yes,
it just
yes.
explains who the person is.
Yeah,
It explains
yeah,
their
yeah,
ethnicity,
Yes,
where they live.
yes, and also like the pronouns too, because sometimes people are like transgender.
Right.
Maybe like 20-year-old transgender male
Okay.
assigned birth at female,
Okay.
assigned female at birth, that kind of thing. Yeah.
Right.
So all the details matter. We need those.
Okay. So the details matter. And I
Yeah,
like that you
yeah.
said that, because a lot of forums nowadays are asking, and a lot of the clients, like even from where I work, they're asking, why are you asking me this? Because this is another trauma-informed
Yeah.
forum that needs to be on all the forums, so that you meet the person where they're at. And if people identify as transgender, then
Yeah.
you need to respect that.
Yes. And so, because I've funny you say that, because I've had a patient that came to me. She was assigned female at birth. We came, did the interview, did everything. I wrote my notes. Then she called me, like, because she wasn't sure whether she was going to see me. They weren't sure whether they're going to see me
Right.
going forward.
Okay.
So they were just coming to test the waters.
Okay.
So after we met, they were like, okay, he's a nice guy. Then they emailed me the next day, like, oh no, FYI, I'm transgender.
Okay.
I'm non-binary.
Nice.
So I had to go back and change note, but at least they told me.
Right. Yeah.
Because you want to be respectful of people.
Yeah, and that's what I was saying. Like nowadays, those questions are on the forms,
Yes.
so that we don't forget that, and that's very important. Is key to working with people and meeting them where they're at,
Yeah,
and
yeah.
building that rapport to get to know who they are.
Yeah, so that's very important, that the gender, because it's a difference. The sex and gender are two different things.
Absolutely.
Sex is what you're born with.
Right.
Gender is the role.
It's what you identify as.
But many people interchange that. They use those terms interchangeable.
Right.
Or they just say sex when they mean gender. Yeah.
Right.
And then there are some people that, I don't know, sometimes I feel that they take it too far, because they say, I want my kid to identify the gender. I'm going to just say they
Right.
until they
Until
born.
they-
Yeah.
Right. And that's a respectable thing
Yeah.
too. You know,
Yeah.
you have to respect them
You
for
got
who
to,
they
you have
are.
to, you have to, yeah.
And if you want to build that rapport with them, then and meet them where they're at, then and if that's who they identify as, then that's what you have to respect them as.
So you got to get that information.
Right.
Education too.
Right.
What's the education? Are they in high school dropout? Do they go to college? Do they is it a master's degree? What kind of truth are they in? So you want all the information. That's part of the demographics.
Right. So all of this information is key, because like I keep stressing that it's important to meet the person where they're at, to know these types of things, and you're getting more of a background on who these people are to build a greater rapport.
And you need a picture. That's a picture of who the person is,
Right.
who they are,
Right. Where they come from.
where they come from,
What they're doing in their life. It just helps.
and who do they live with at home?
Right.
To live with the mother and father.
Right.
They live alone. There's a spouse with and the kids from the same person. All that stuff
Right.
matters.
Right.
People might think it doesn't matter. It does matter.
It does matter
Yeah.
because when people come in, when somebody's dealing with depression or anxiety, their environment definitely matters. Who they're living with, or because the person who they're living with could be the person that's triggering their anxiety or depression, or the environment where they live, the neighborhood they live could be triggering their anxiety or depression. So that's very key.
It's very good. It's very good because those things we can medicate.
Right.
That.
We can't medicate that. And we can't uproot everybody and put you in a better neighborhood. Where you live is where you live.
Yes. So we got to find the skills for you. Because I know some NP, some people would say, oh, it's depression, medication. No.
Right.
We got to get the source of the depression.
Right.
You live in a neighborhood that's over-policed, you're going to be anxious and depressed all the time.
Right.
Stressed out each time you see a cop car.
Every time.
We can medicate that.
Right.
We can give you other mechanisms.
Right.
Or sometimes you depressed because you're a victim of domestic violence.
Right. But you have to go home to the same person every day because you don't work. So it's like...
And we can medicate that.
Right. Yeah. No, that's real. So being able to know
we got to come up with a plan. Like, what do you do?
Right.
Yeah.
Right.
So all those things are important. Are you living with your mother, your father, are your kids, you live with your parents too, in-laws, all that stuff.
Right.
All that matters.
It does.
Because those things are stresses. Can be stresses.
Right.
Yeah.
Most definitely. I agree because it's stressors. Life is tough for a lot of people right now. And a lot of people, in America have to live with other family members because, that's just the way the life is right now. A lot of people can't afford to live on their own. So being able to come up with coping skills and knowing that information, it'll help you as a mental health nurse practitioner to know how do you help this client. Patient.
Because even the setting too. Because some patients, because I know there's a new phase now. Everyone, all the NPs saying, new NPs, just see everyone in remote via telehealth.
It doesn't give the human experience though. I mean, for some people it's okay. For some appointments it's all right. But being able to sit face to face with somebody, it's
convenient for the patient.
Right.
But what if someone is sick of their kids?
Right.
And they do tell it at home. They can't talk about the kids at home.
Right.
The kids are there.
Right. Yeah, they can't open up. They can't really share freely.
The husband is the one that's abusing.
Right.
Or his wife abusing.
Right.
Then you do telehealth. They can't share that at home.
Right.
So you meet the person at the office.
Right. Yeah, that's another
then
big barrier.
Talk. Yeah.
Definitely.
Telehealth is good.
Right.
But only for certain reasons. But person one-to-one is the best.
Absolutely. Yeah. I think face-to-face is key in person for sure.
And then we're going to move on to chief concern. The chief concern is what brings you here.
Right.
What triggered the event? What made you come today?
Yes.
You've been dealing with this issue for 2 months. Why today?
Right.
Did someone nudge you and say, you got to go?
Yeah.
Is the event that happened? Or were you like driving on the freeway and someone cut you off? You got angry. Like, I got to take care of this.
Right.
So chief concern is what brings you here today.
Yeah. So what kind of chief concerns do you normally get? Because I know that a lot of people are mandated to go to therapy or they're mandated to be seen or a lot of people have to go because of the courts or somebody's probation or somebody's telling them that they have to go to these things.
And that can be a concern too. But people like that normally are not buying in.
Okay.
They're just there because they want you to sign off the signatures.
Right. Yeah.
You can't litigate change.
Yeah.
They're forced to be there.
Right.
So they just going to be there and get the signatures.
Right.
But sometimes people like, I was crying too much. And my family like, oh, you got to go get checked out.
Right.
Or something. Usually you want the chief concern to be in the person's words.
Okay.
Like you want to code them. Like,
or I'm sleeping too much. Like I sleeping. I don't have enough energy. I don't know. Normally on my, my normal baseline is getting up every morning and going to work out. But lately I've been sleeping.
The job stressed me out so much. I'm working 5 days, 6 days a week.
Okay.
They want me to work 7 days a week. So now I'm stressed out.
Yeah.
That's the chief concern. Like that's the thing, that the trigger that made them come to see you.
Okay.
And then we're gonna talk about the history of present illness. Like within the 6 months or 6 months, have you been dealing with that issue?
Oh, okay.
Yeah.
So you need to see the history and how long. Do some people not remember? Because I know that a lot of people just end up burnt out. So a lot of people don't know the warning signs of depression. They just at some point feel, I don't have any more energy and I'm burnt out. So do they not know the warning signs? How do you get a clear understanding on the history of when did this start feeling like you were depressed? You know, what happened in the moment, and why didn't you reach out for help sooner?
Yes, but that's an excellent question, because there's some people that don't know they're depressed. They think depression is just a rite of passage. They think it's something everyone goes through.
Right.
Especially people that are like, oh, depression is generational, minorities, people of color. Your grandfather was depressed, your father was depressed, you were depressed too. I've heard people tell me, well, I felt like killing myself 4 times. Never sought help. Or they'll tell me, oh, my son said, when they say to the father, oh, I'm feeling suicidal. The father said, well, I felt the same way before. And nothing's done. So some people don't know this. They just think that's normal pathway. The thing is, it is what it is.
Right, and then they have to go through it like it shall pass. And a lot of people
It doesn't
don't
pass.
reach out to help
Yeah,
for
yeah.
help, and it just gets worse.
It gets worse and worse until they can't take it. I've had patients who are put on antidepressants, and then after a few days, they come and say, wow, it works. The medication works. But yeah, that's what it's for.
Right.
Because they just thought they had to feel that way, because they've been feeling that way for a long time.
Right. And a lot of people don't take medications because of the stigma on medications, because I don't, we've talked about it before off screen and stuff like that, but there is a big stigma on medications that I'm not going to take those medications because I don't want, I don't want to be a zombie, or I don't like the way they make me feel, or, whatever reasons, a lot of people won't take those medications. But just like any other medications, if you were having high blood pressure, you're going to go to the doctor and you're going to take the high blood medication, high blood pressure medication. So why not take the medication for your mind also? It's also an organ.
The brain is the most important organ in your body.
Right.
That is the most important organ in your body.
Right.
Why wouldn't you just call it brain medication?
Right.
That's what it should be.
Right.
Why would you not take medication for the most important organ in your brain?
Right. So when you figure out the history, so depression, when it's that severe, I recommend people taking medications. I mean, if you can't figure out your own solution, a lot of people say, do other coping mechanisms, do other coping tools, but this is a coping tool. Medication is another coping tool. So don't.
And it's not either or thing. You can use medication and then coping skills.
Right. Together. Right. And it's not like you have to be on the medication for the rest of your life. No. Because depression and anxiety, some of it is life events. Sometimes things happen where it might trigger you to go in a deep depression, but it doesn't mean that it's going to last for the rest of your life. Yeah.
It's just like me. When on the first episode, I was talking about how I was depressed for like 2 years.
Yeah.
And no one in my circle, nobody ever suggests medication. Nobody. Because they come from a place where people don't do that.
Right.
But if somebody say to me, hey, take it.
Right.
I would have done that.
Try it at least,
It
if it's not for you, there's multiple medications. What works for you may not work for me. What works for me may not work for you.
Yes. At least give me the chance to say no.
Right.
But no one ever did.
Yeah.
I even went to my doctor. My doctor was treating me for my seizures. I guess I was just putting on a brave face.
Right.
He never suggested it.
Wow.
Because I didn't tell him I was depressed.
Right. Yeah. Wow.
But I was. So if anyone suggested, I would have done it.
Right.
So most people who don't take medication over the stigma is because people in the circle
don't
never
take it.
Yeah,
They don't take it. They don't take it. So it's really important. So when you're doing the demographics and you're doing an intake, it's very important for whoever's coming to see you to try to pinpoint and remember exactly when they started feeling these feelings, because the history is going to help you in order to be able to support them. And if you were going to prescribe them medications, what medication might best be for them.
Yes, and also like the past medical history is not for them to just say, "Oh, I've been depressed this whole time."
Right.
It's like when you've been to say a psychiatrist or psych NP before, they diagnose you with something, so that kind of tells me, "Oh, you saw that before."
Right.
So you can take medication
Right.
because you have saw that before, so you can do that.
Right.
But some people, it's the first time ever
Right.
coming to see help, and they are 50 years old. So the first intake is just to gather information. The first appointment, even the second appointment, to gather information.
Right. And during those appointments, I know a lot of people are, because of the stigma on receiving help, and a lot of people are afraid and they don't want to share so much information. You don't normally find out the full story of somebody in the very first intake. They don't, because like when you first see somebody, you don't build rapport that fast, because they already are feeling like nervous of coming to see you, so they're not going to tell you everything.
No, they're not. You just keep information, like you get information over like 2 or 3 appointments.
Right.
Sometimes.
Okay.
And that's if you know when in scrubs.
Right.
If you're in scrubs, you'll never get it.
Right. Right.
Because they see the white coat, the scrub, they're like, oh no, they just sat down.
Right, and that's just like the last episode we talked about, the white coat syndrome.
Yeah.
You know, and
they're already nervous coming down.
Definitely nervous coming down.
So we build a rapport. That's why you don't assess them when they first come in. They're assessing you.
Right.
You don't want to assess them, but they're assessing you like, oh, does it feel safe?
Right.
Is space feel safe?
Right.
All the things. They're assessing you too.
Yeah, that's 100% true, because even no matter where you go, whether it's a hospital, a doctor's office, dental office, anywhere you go, you're going to return based off of how you feel. And if you don't have a good, true gut feeling on the atmosphere, then you're not going to return. Chances are you're not going to return.
And if you do return, you won't share as much. You won't share nothing.
Right. And
what are you doing there? You're there for the provider, for the NP.
Right.
Because that person should be there for you.
Yes.
So if you might just go there just because you're forced to go there by the courts or whoever.
Okay.
But you're not getting any information.
Nice.
So what are we doing here?
Right.
Yeah. So that's why the past medical history is important. That shows that someone has sought help before.
Right.
They're no stranger to mental health care.
Right. So be honest about your past, your history, and everything. Share as much as you can.
And so you get the information over weeks, over 3 or 4 sessions.
Okay.
And you don't have to decide. You tell the patient, the first session, you can tell the patient, today we're just collecting information. That's all we're doing. Because sometimes people are expected to live with a prescription.
Right.
Or some NPs, new psych NPs, feel that they have to write a prescription the first time. You don't have to. You gather information.
Right. Gather the information.
Yeah. The next time, or the time after, you do that.
Okay.
Because even some people of color, they don't like to take medication. So if the first appointment, then you want to suggest medication, they're like, oh, then I come back.
Right.
Because it's 2 minutes. You're so minutes for less than an hour.
Right.
They want to prescribe this medication. I will take for life. In their mind, they think they're going to take the medication for life.
Right. Yeah. No.
So you have to ease in. Even if you feel like they gotta take medication, just maybe say, think about medication. Don't force them at the same first appointment.
Right.
Then after we build rapport, next time we can talk about that.
Get to know them. What is the HX?
HX is history of present illness.
History.
X is shortened for history. Yeah.
Oh, okay.
The X is X is for history. Yeah.
Okay.
So history of present illness. Yeah.
Right.
So what triggered them to come?
Okay. That's good.
Yeah. Anyway,
what triggered?
It was nice being here with you guys. And if you have any questions, concerns, just reach out. And we'll see you next time on the next episode.
Thank you so much for having me.
You're welcome.